Thank you. Going on to the last talk of the session.
So I welcome Ms. Rosemary C. Anthony for the topic use of prisms in spectacles and low vision aids.
Good morning, one and all. Myself, Rosemary. Is it audible? Yes. Today, I'll be speaking about use of prisms in spectacles and as low vision aids. In ophthalmology practice, we use prisms both for diagnostic as well as therapeutic for purposes. Here, I'll be discussing only about the therapeutic applications of prisms. So, it can be used in variety of scenarios like correcting heterophoria, diplopia, and nystagmus, and as low vision aids. So, when do we think of prescribing prisms? So, we can think of prisms when the patient presents with asthenopic symptoms, and when you make an assessment, you find that patient has a binocular dysfunction. In such scenarios, you can think of prescribing relieving prisms for correcting the misalignment. So, before prescribing prisms, you have to make two clinical measurements. One is the magnitude of heterophoria or the amount of deviation, and you should look for the fusional vergence reserve of the patient. Fusional vergence reserve gives you an idea of the ability of your vergence mechanism to adapt to this misalignment. So, after making the assessment, the least prism which is required to relieve the patient's symptoms can be prescribed. And you should perform a prism adaptation test prior to prescription, and a phoria greater than 10 prism has to be referred to a surgeon. Then how do you do a prism adaptation test? Now you should have obtained a prior measurement of the associated phoria. Then you place prism in the appropriate base direction in the trial frame. Then reassess the phoria and give the patient an adaptation time of 10 to 15 minutes. After adaptation time, you again make an assessment of the heterophoria, and if the value measured after the adaptation time is same as that prior to the adaptation, that indicates that patient has a strong vergence adaptation, and this patient is not going to be benefited from prism glasses. So in such cases where prism adaptation is positive, you needn't give prisms in spectacles. There are various techniques by which you can incorporate prismatic effect. If the patient is wearing a refractive correction, then a symbol and if your prism demand is very low, a symbol decentration of your refractive lens can give the desired prismatic correction, or you can give it as ground down prisms. Lens will be thick towards the edges of the towards the base of the prism. That's a cosmetic disadvantage while giving a ground down prisms, but each eye can tolerate a prism diopter of 6 diopters. And in case of high prism powers, Fresnel prisms are the option. So once you prescribe, you should mention the prism power in prism diopters with the base direction specified. And you can give both horizontal and vertical prisms individually, or in case if both elements are present, you can give it as a oblique prism. The power of the resultant prism and the direction of the base direction can be calculated using the symbol Pythagoras theorem. Here in this case, you can see right eye has a +4 with 8 prism and left eye is +2. So when you give this as a prism, what happens is right eye becomes thicker. So it may not be cosmetically very good. So in such situations, you can think of splitting prisms. So while horizontally splitting prism, you can split the 8 prism into 4 and 4. So if it is horizontal, same base direction will be additive in function, whereas opposite base direction will be subtractive in function. But in case of vertical splitting, it will be vice versa. Now coming to Fresnel prism. Fresnel prism has the advantage of it being very thin, and you have it in a wide range of powers ranging from 0.5 to 30. It can be used in nystagmus, in stroke patients, in hemianopia, etc. So while fitting the prism, you should decide upon the power of the prism and base direction. Then you cut the Fresnel prism to decide size and shape of your carrier lens or the spectacle lens, and the plane surface of the prism has to be attached to the inner surface of the spectacle. While doing it, you have to submerge the spectacle lens and the prism in lukewarm water to avoid air bubble being trapped between the two. Now we will come to clinical conditions where prisms are applied. In small heterophorias, we can give it as relieving prism to reduce the Virgin's demand. In exophoria, we give it as base in, and esophoria, base out. Prior to giving relieving prisms, you can try exercises to improve the patient's Virgin's demand using prisms in office. Then in nystagmus, in order to correct abnormal head posture, you can give prisms so that the null point can be shifted to the primary position. But the power requirement for prism would be pretty high and the patient may not be able to tolerate. Anyway, prisms can be used for diagnostic trial prior to surgery. In bedridden patients, vertically yoked prisms can be used, or they are called as recumbent prisms, to help them read in their supine position. In rehabilitation of stroke patients or CV, in case of CVA, you can use horizontally yoked prism. Patient may have visual neglect or visual inattention to the affected side, so their posture may be affected. Giving horizontally yoked prism may help to correct their posture and midline shift. In children with autism or with attention difficulties, children may present with toe walking, hand flapping, etc. In such cases, vertically yoked prisms would be helpful to improve their posture, gait, etc. and it enhances their attention and engagement. And homonymous hemianopia is a scenario where prisms are used as field expanders, where your base direction of the prism should be towards the affected side or the non-seeing side. Here in the first picture is a left homonymous aniopia. In the second picture, the patient views through the prism, so the field of view has been expanded towards the left. But prescribing prisms are also associated with many problems. Here in the first picture, you can see it is the prism-free view of the patient where a scene is perceived, and the right side you can see it's evident that left side of the field of view has been expanded with prisms. You can see the rear part of the red car and an extra door is seen. But you can also notice that on the right side picture, the front portion of the red car is missing. That is due to the apical scotoma. And here you have a picture of the patient with the left homonymous hemianopia, where can you see the red cross in the first picture? So when a patient is fixing at the red cross, then he can see the right side of his visual field, but the left side is missing. Now he is wearing a prism. So in the next picture, you can see his fixation is shifted slightly towards left. So his left eye views to the prismatic portion. So he can see his field of view has been expanded and he can see a person standing towards his left. But you can see that the right arm of that person is missing. That corresponds to the apical scotoma. Now in the third picture, he makes a scanning movement slightly again towards the left. So both eyes are viewing through the prismatic portion. So he can see two images. This causes diplopia and confusion. So these aspects has to be explained to the patient, or you should give him adequate training so that he get used to this new spatial orientation. Otherwise, he may find it difficult to move around. So solution to some extent to this problem is prism multiplexing, where you use LE-Pelli lenses. LE-Pelli lenses are simply sectoral prisms which are placed superiorly and inferiorly on your carrier lens. So what happens is the central area is prism free and patient can have binocular single vision, whereas superior and inferior portion can be used for field expansion. So training with prisms is very important before dispensing. 20 minutes per day activities for 4 to 6 weeks is recommended for the patient to get adapted to prisms. So peripheral prisms are often a mobility device. Patient may have problems with reading activities and near vision tasks when they are wearing an inferior sector prisms. So in such cases, you can use prisms as clips on. So it can be attached to the patient's refractive correction whenever required. On reading, they can remove the clip on. It is easy to get, and Pelli lens have a SLAM technology clip-ons, that is single lens attached by magnets. Can I go on? Yeah, okay. So homonymous hemianopia. two main aspects that the patient complained us. One is colliding with obstacles or colliding with other pedestrians, and a wider field of expansion is very required in such situations. But our Fresnel prisms gives a maximum of 30-degree field of view expansion. The maximum power of Fresnel prism can provide 30 prism of field of view expansion, but that is not enough to avoid collision. Study says that you need to have a 45-degree of field of view expansion to avoid collision. So, future of prisms is multi-periscopic prisms, which consist of a cascade of half penta prisms. It is used in binoculars usually. It provides a 45-degree shift, and it makes use of the principle of double reflection rather than refraction in our regular prisms. So, adapting to prisms is often disorienting to patients initially, but training is very crucial to avoid trips and falls. Thank you.
Thank you.